We're happy to have her from the University of Kansas Medical Center. Dr. Befort acquired her bachelor's degree at University of Texas at Austin and a master's at Arizona State, and she got her doctorate degree at Colorado State University. She's been a faculty member at the University of Kansas Medical Center for many years, developing and studying lifestyle interventions and obesity treatments for cancer prevention, particularly among the underserved populations. She's currently professor of population health, and she serves as the associate director for the Cancer Prevention Control program at KU Cancer Center. Dr. Befort is known at KU Medical for building a pragmatic clinical trial research infrastructure in their rural primary care network. And the unique aspect here is that it engages local providers and clinical staff in rural communities as full partners in their clinical research efforts. She's garnered a lot of funding from the National Cancer Institute, from ACS, from the Komen Foundation, and from the PCORI program. So we greatly appreciate Dr. Befort joining us today. And as part of my introduction, it's my honor to award her with the University of Colorado Cancer Center's Cancer Warrior Award. And Adela, oh yeah, you're gonna show the award. So this award is given in recognition of Dr. Befort's contribution to cancer research and her dedication to mentoring the next generation of scientists who will undoubtedly have a huge impact on the prevention, treatment, and control of cancer in the coming decades. So I wish we were giving you the award in person, but Adela will be in touch afterwards, Christie, for on the details of this award and to get the award to you. So the title of Dr. Befort's talk today will be Obesity, Cancer, and Weight Control Interventions in Rural Settings. So Dr. Befort, the time is yours.
Thank you, Paul, and thank you, Adela. And I don't know who came up with the award idea, but that is super nice and kind, and I appreciate that. Evelyn Barayo was my PhD dissertation chair, and I think I was your first student, Evelyn. Is that right?
Yes, you were up there, one of the first and brightest.
Oh, you're kind. So anyway, I wish I could have come in person, but I will come out at some point because I would love to meet with many of you in person, and I love Colorado. So, and we are kind of neighbors. I mean, we are neighbors, and the work that I do definitely is right on the Kansas-Colorado border. And I think those of you working in the rural setting or maybe moving in that direction will understand many of the things that I share in my talk today about working in that setting. So pull up my slides. Okay. So I'm gonna talk just a little bit of background about rural cancer disparities, how obesity contributes to that, and then go into a little bit of the mechanisms about why we may have some of these disparities in obesity across rural and urban gradients, some of the interventions that have been done in this space, and then talk about some trials that we've done here in the Midwest. The CDC put out some data in 2017 looking at rural and urban cancer outcomes. And at that point in time, the National Cancer Institute also launched an initiative to try to increase their portfolio of funding that addressed cancer in rural communities. They've had a variety of supplements and RFAs that has built a larger network of scientists, especially behavioral scientists, addressing some of these gaps. But the data from the CDC really showed that cancer death rates, age-adjusted cancer death rates, are declining at a slower rate in non-metropolitan counties compared to metropolitan counties over time. And this disparity is really mostly driven by screen-detected cancers, breast, colon, cervical, and lung cancer, and is due to a variety of factors, including lower screening rates and diagnosis at later stage as a result of that, also access to care issues, with one factor being a delay in start of radiation therapy, but then also behavioral factors in the primary prevention area related to obesity and tobacco use. So I think probably everybody knows at this point that obesity is linked to many cancer types, 13 different cancers. It is projected to overtake tobacco as the top preventable cause of cancer, estimated to account for up to 20% of cancers in women and 14% men, linked to breast, highly linked to endometrial, ovarian cancer, and then a host of GI cancers. Once cancer has developed, obesity also contributes to rates of recurrence and mortality for up to 7 different cancer types. The national academies, ASCO, a variety of professional organizations have put out position statements and held workshops to promote better access and implementation of weight management and physical activity curriculum for cancer survivors. In my meetings this morning, I learned that you guys have a great program there. I think we've made more progress in the domain of physical activity and exercise oncology than we have necessarily obesity treatment and weight loss, but both of these are really important aspects of cancer survivorship care as well, although we have a long ways to go in terms of universal implementation. So the pathogenesis between obesity and cancer is really multifactorial, related to insulin resistance, abnormal insulin growth factor signaling, dysfunctional adipose tissue and the adipokine production that comes from that, chronic subclinical inflammation, and alterations in metabolism at the microenvironment, also potentially some microbiome contribution. So this is an ongoing area of high interest to translational scientists to really try and disentangle all these different mechanisms, which vary between different cancer types, as well as different microenvironments. So my work has really honed in on rural disparities. This is about a decade ago now, we showed with NHANES data that rural Americans do have higher obesity rates. That has since been replicated in 2018. And the most alarming thing about the most recent analysis of NHANES data is that class 3 obesity, which is the body mass index over 40, it has been increasing at a rate 3 times faster in rural communities compared to urban communities. And for some cancer types, it's the higher BMIs, cut point of 35 or 40 that really promotes more cancer risk. If you look at BERFIS data, which is self-report, so it's going to show an overall lower prevalence of obesity, but you can look for trends, and you can, because it's a broader sample, you can break it down by gradients of rurality. And that data really shows that it's the smaller and more isolated communities where we see the highest rates of obesity. You guys are a little bit of an anomaly in Colorado. I don't know if you're still the only state of different color on the obesity prevalence map, but you were for many years. But if you break down obesity prevalence by region throughout the United States, this rural gradient holds up for men and women, with the exception of the western region for women. You don't see it there, but it's not just one part of the country where you see this, but it's across the country. I have a variety of pictures throughout my slides, which are all taken from my family's hometown, which is claim to fame is it's the center of the continental United States, Lebanon, Kansas. But just, some of the drivers of this disparity, part of it is sociodemographics, older age and lower socioeconomic status, but it's not simply that. It also has to do with place of residence itself. Differences in physical activity and diet behaviors and the contextual factors around that that have to do with the built and natural environment, access barriers to either commercial programs or medically based treatment options for obesity, and then cultural norms that can drive the physical activity and diet behaviors. You might often see it referenced that rural Americans have less physical activity And that's something we really need to be careful in making blanket statements like that, because it turns out, I think it's very highly context dependent. It depends on the population, and it depends on how you're measuring physical activity. And this is just one paper demonstrating this. It's from NHANES data, so it's a nationally representative sample, and they have both device-based measurements of physical activity from accelerometers, as well as 2 different self-report measures. And the results vary. The rural-urban comparisons vary by the type of measure that's being used. So if you look at the objectively measured physical activity, it's only the larger rural areas that have a lower physical activity level. The small rural is no different. And then if you look at the self-report, you can see the small rural actually has higher what is called household activity, which may be considered part of like manual labor. So a lot of the work in this space really is very context specific, and you have to know kind of your local setting in the rural environment. The environmental barriers to physical activity are real. They're not very well studied, and there's very few kind of head-to-head rural-urban comparisons. A lot of mixed methods type work has been done in this space. There's some newer quantitative measures out, and some of the GIS type methods of scanning the environment, but different things related to access. Kind of the big things that really stand out in the literature are related to socioeconomic status and lack of well-maintained sidewalks, rundown neighborhoods, loose dogs. In the Great Plains here in Kansas and eastern Colorado, I think you all probably know what the winds can get like and the barriers to outdoor activity from that. And then just the social cultural aspects of it, seeing other people walk and exercise, walk for exercise or exercise for leisure is a pretty large determinant. And I think that's where you guys really have a good thing going there in Colorado. But here in Kansas, especially in the rural environment, you just don't see it. This picture right here is Lebanon, Kansas, where my family's from, and everybody lives within 5 minutes walking distance to this tiny little town, but they drive to get there. So some of those social cultural environmental barriers are things that we address in some of our interventions. The food environment, very small, expensive grocery stores. And again, I'm speaking mostly of small and isolated rural areas, frontier areas. Food, 50% of people's food budget is spent eating out or takeout, and in smaller rural communities, oftentimes this is convenience store type foods. It's just difficult to get the healthier, fresh options. So the intervention space in this area has been growing as the NCI and other funders have been soliciting more proposals addressing rural populations. NCI actually said their portfolio in 2017, I think, was 3% of it addressed rural populations, and they had a goal to get that up to 15%. There's, my scan of the literature, there's been about 50 studies that have been done. 20 of those have been randomized trials. Some of them are specific to treating obesity. Some of them are simply diet and exercise kind of lifestyle interventions. They all sort of have their niche in this. A lot of the work's been done in the South in African American populations. There's been some work done in Texas and Hispanic populations. We and others have done some work here in the Midwest in majority white populations. And I'll tell you about a couple of the trials that we've done and one that we have that's ongoing. But I wanted to show this heat map of the population density. So you can see the work that's done in the South and in the Northeast. They have a higher percentage of their population is rural, but it's not as frontier as we are here. And when we think about how do we reach patients and how do we sustain interventions, access has to do with the socioeconomic barriers, but also the geographic spread that we deal with in our region. my conversations this morning with Heather and Ryan, we talked a lot about recruiting into research into clinical trials, which is part of the question of how do we reach rural questions, but that's really the tip of the iceberg when we want to think about having a population level impact. And the reach question is really multifactorial in how do we have a steady referral stream into these types of interventions, and then how do we deliver the intervention, particularly when we talk about something like obesity treatment where the interventions are intensive. It's a lot of visits in order to follow the treatment guidelines to have as many people as possible successful. So I've worked in all of these settings. The first study I did in the rural setting was through cooperative extension. I've done work in schools, primary care, cancer care, and our delivery mechanism is really focused on telehealth, although we've more recently trained local clinicians to deliver this as well. And so I'll tell you about a variety of those. So this is the study we did in cooperative extension in southwest Kansas or southeast Kansas. And it was a phone-based intervention. And we wanted to ask a pretty simple question, but one that hadn't been asked before, which is, can you do this in groups over the phone? At that time, it was just conference calls. And it's more, we know it's more, cost, it's a better use of costs. It's, you can treat 12 people at once versus one. But traditionally obesity treatment's been done in groups, but nobody really asked the question, is it more effective? Particularly over the phone. So we worked with Extension to recruit into the study, and we worked with them on site for data collection, but they were not involved in the actual intervention delivery. We did try to connect it to other programs they had going on with cooking classes and stuff, but it was not an implementation within their setting. It was more of a collaboration and a referral source. But anyway, our findings did show that the group approach was more effective. It dominated from a cost effectiveness standpoint, and that it was more effective and less costly. And importantly, it didn't matter whether or not the participants preferred individual. We asked them before we randomized them, do you want group or individual? And then we looked at their preference to see if it mattered. And even the individuals who said they really wanted individual coaching, which was 75% of them, they still did better in group. And the group benefits really stem from the support, accountability, information sharing, and learning. Although not all groups are the same, but it's been a modality of intervention delivery that we've carried forward in all of our trials. So we took this approach and we really wanted to focus more on the extended care phase of obesity treatment, which is after the first 6 months. I don't want to say it's easy, but it's the real challenge isn't to help people lose weight. The real challenge is that, that year or more after they've lost weight and trying to reduce the amount of weight regain that you're going to see during that time frame. And it's, engaging in telehealth or asynchronous mHealth type interventions oftentimes can be relatively short-lived. And long-term engagement is really sort of the question of how do we promote sustainability at an individual level of these lifestyle behaviors. So the next study we did was in breast cancer survivors, and we wanted to ask that question of will these conference call visits help people maintain their weight loss after they've lost it? So we enrolled 210 breast cancer survivors in the rural Midwest with pretty broad eligibility criteria, any stage except for metastatic, a pretty broad body mass index of 27 to 45. They had to be cleared either by their oncologist or their primary care provider. And then they all received 6 months worth of the intervention, and then they were randomized either to continue with the group intervention or to have a low-cost alternative, which was just simply newsletters. We had really great weight loss in this trial. 85% of those that enrolled lost at least 5% of their body weight, which is at the lower end of the clinical threshold, and were randomized into the extended care or the maintenance phase. These are the 9 local community cancer centers that we worked with in this trial. At that time, it was the NCI Community Cancer Centers program, which then became NCORP, and then our network, Midwest Cancer Alliance, is now called the Masonic Cancer Alliance. Our sites in Nebraska and Iowa came through the NCI CCCP program. And we traveled to all of these sites. I had conversations this morning about how do you recruit, how do you refer, and we worked with them to send out mailings from their oncologists and their clinicians, inviting their patients to contact us if they were interested. And then we also asked them to refer patients when they would see them, although we had a pretty broad time since treatment range, and so many patients weren't actually coming in the door in our recruitment window. And then we traveled to their locations. We did all of the data collection for this study on site, including blood draws. We had our own, I had my own staff processing the samples, and we would bring it back on dry ice. And you know, as we move forward in trying to incorporate our translational science into rural populations, one of the important questions is how do we get samples from folks? This was a pretty time-intensive way of doing things. So we looked at our recruitment went great for this study in terms of the trial. Like, we recruited on time and we didn't have any problems, which is like a big yay factor for doing research. But there were also some concerning things in terms of how do we sustain programs like this, because only 5% of our study sample came from actual physician referrals. So we weren't able to really accomplish great integration into clinical care and getting the referrals that we were hoping we would get that way. The mailing worked great. And this was an effectiveness study, so we had pretty stringent eligibility criteria, and we saw a 29% enrollment rate. I'm going to come back to this because we've moved to more pragmatic designs with a much higher enrollment rate. And then this was our primary outcome, looking at weight loss and then weight regain from 6 to 18 months. We did have a significant effect of the group phone-based intervention during the maintenance phase. As I mentioned, the weight loss that we saw initially was really kind of astounded us. This is typically you'll see about a 7-kilogram average weight loss in most obesity treatment trials. These women were just highly motivated. The group approach works really well in this population. It was really designed not just for the lifestyle changes and the weight loss, but also to meet their unmet support needs. And they bonded. I still get contacts from women in some of these groups wanting this to start back up again. At 18 months, 75% of them were still below that 5% weight loss, or above the 5% weight loss clinical threshold. So the findings were great, and we also looked at costs. And during the maintenance phase, the incremental cost was less than $200 a woman to participate. So it's a really good model of care, and the problem is it kind of went nowhere because there was no way to sustain it. There's not a payment for it. We didn't get good physician referrals. So it was kind of like the age old, we did the study and then it was over and done with, which was a little bit of kind of professional disillusionment for me. And I'll come back to that, why I ended up moving into doing primary care-based research. So we looked at our accelerometer physical activity data and just confirmed what's known in the literature, that physical activity tracks with weight loss and weight regain. So these different lines are 4 different groups high weight loss, which was a 10% threshold, versus low weight loss and high regain, which was a 5% regain threshold versus low regain. And particularly these are the folks who didn't lose 10%. These are those who did. Those who maintained their weight, they kept their physical activity up. Those who regained their significant weight loss, their physical activity plummeted back down. So maintaining physical activity is hugely, hugely important for maintaining weight loss. I was talking to Heather about this earlier. It's just an interesting side note. When we compared our device-based versus our self-report physical activity data, the women who did not accomplish a 10% weight loss and went on to have a high amount of regain of the weight they did lose had a really stark self-report bias in their physical activity. It's this black line. So their device-based measurement was pretty flat, but their self-reported a large increase in physical activity. So I think there's maybe some novel things that could be done here with predicting successful versus unsuccessful weight loss maintenance. We also looked at serum biomarker changes, but one of the ancillary questions we were interested in is how much weight loss do we really need to see to impact biomarkers in the cancer pathways, and how much weight regain do we need to prevent? And there hasn't been a lot of studies on this, particularly looking at the amount of regain aspect. And we saw linear trends for things like insulin, but for the adipokines, it really supported this 10% clinical threshold, particularly for adiponectin. Leptin was the optimal threshold was 8%, and then the AL ratio was higher at 15%. For weight regain, the most optimal threshold of preventing amount of regain was 2% of weight. And when we looked at the impact on these biomarkers by the 10% weight loss threshold, we found a significant difference, highly significant difference in the case of AL ratio between those who lost more than 10% versus less than 10%. And I'm not a translational science, but I think AL ratio is a good marker of dysfunctional adipose tissue and potentially an important primary biomarker endpoint for weight loss trials in cancer prevention and survivorship. And then for the regain threshold, we looked at 5% as our median split. Interestingly, adiponectin continues to improve even with weight regain, but it improves more for those who limit the amount of regain that they have. Leptin and insulin revert back, partially back to baseline with weight regain. So some of the reach and implementation lessons learned from this trial, the group-based telehealth modality worked really well, great attendance, particularly in phase 1, but even in phase 2 into that second year, 60% attendance is pretty good. The accountability, the group cohesiveness was a really important intervention component, but we really needed to think strategically about how do we enhance referrals and participation rates from local oncology settings. And about this time, implementation science was really taking off. It's another area where NCI has had, I think, a significant influence on the field and funding implementation science centers and just having a whole group focused on implementation science. And I wanted to move into what felt like would be lower hanging fruit in terms of trying to implement obesity treatment at a population level, which seems like it should be primary care. If we're not even doing it in primary care, how can we do it in oncology care? And so I started thinking about doing a trial in primary care focused more on primary prevention. So this is kind of some things that have been happening in the past decade to try to move the needle in access to treatment in a primary care setting. So CMS approved billing under an obesity diagnosis for the first time at the end of 2011. Prior to that, you couldn't even bill under an obesity diagnosis. And then position statements have come out from professional societies, treatment guidelines, provider competencies from 20, 30 some different professional societies came out just in 2017. And then we have these GLP-1 agonists that have come on the market in the last couple of years, which are highly effective, and folks are wanting access to them. And that's probably been the biggest thing that's moved the needle. But it's still really, really falling short on what it could be because the system is just not set up for it for a variety of different reasons. One of the biggest ones being highly variable insurance coverage, but also still big training gaps for health professionals, gap in integrated care. People aren't trained to work up to their level of expertise where you have integrated care between behavioral health, dietitians, and then the primary care providers. And you look at that in a rural setting and it's complicated more so by workforce shortages in those settings. So this exciting thing that you could finally bill for obesity treatment really, really fell short because of the way it was designed. It came out and it was required to be face-to-face in office, only $27 a visit. They did provide up to 14 visits in 6 months and continuing monthly after that if the person had someone on a weight loss. But the system problems were still there, and so less than 1% of people that could have received this benefit actually received it. So PCORI funded a large trial that we did in primary care, and they came out with a RFA in 2014 in response to this low uptake of intensive behavioral therapy for obesity in primary care. And they put a call out for investigators to propose large trials that would test alternatives to that Medicare model. And it was intended to be an underserved setting. So we competed for that and were funded with a group at Pennington in Louisiana. And PCORI now has a mechanism out to implement the results of our trial and the trial that was done in Louisiana, and Colorado is one of the places doing that. Jody Holtrup and Andrea Netterfeld. I'm collaborating with them to implement what we did in our Repower trial in rural clinics there in Colorado. But we decided to propose a 3-arm trial where we had 2 alternatives to the Medicare intensive behavior therapy provision. They were both group-based. In one approach, we trained the local clinicians to offer group visits in their clinics. We modeled this after patient-centered medical home principles, which was more of kind of a hot idea at the time. And then the third approach was our telehealth group-based intervention, which we modeled after the disease management industry, these wellness programs, things that are contracted through payers. So we had no control arm in this trial, which was one of the unique features of it, and also what made it a large trial, because we had to power on a pretty small effect size with no control arm. So it was 36 clinics. Each clinic enrolled about 40 patients. And then the clinic was randomized to one of these 3 approaches of delivering obesity treatment. The patients were in the intervention for 2 years, and weight change was our primary outcome. And then we looked at a variety of secondary outcomes, quality of life, sleep, stress, metabolic syndrome, and some implementation process measures. A couple unique features about this trial. One, it was the first study to directly test alternatives to what Medicare was covering. And also, we designed it to be highly pragmatic. And part of that was the language that was in the RFA that PCORI put out. But also, I've really taken a strong interest in trying to do more real world implementation of our interventions and to measure and see what kind of outcomes we get when you do that. So any of you are familiar with the PRECIS criteria. It's a way of kind of grading your trials on how real world they are on a variety of different criteria. This is our own grading, which is biased. I'm sure, but regardless, we did intend to design it as highly pragmatic. So some of the ways we did that, we had very few patient exclusions, which you can see in our eligibility rate, which was 87%. Most trials will see, a 30 to 50% eligibility rate. In the two arms where they delivered an intervention in the clinic, it was their employees. We didn't pay them. We did pay the clinics for being involved, but they decided if they were going to pay the actual people doing the intervention or not. They were selected locally. We were very hands off with that. And then we went about training them in a very pragmatic way. We didn't do the kind of training that we're used to doing in our research, where we're more focused on fidelity and effectiveness. We did training that they would do in real world clinical practice with, we had CMEs, we did one day workshop and then another additional day for those doing the group approach so they could learn the facilitation. And we had optional monthly telementoring and webinars. The intervention, I'm not really focusing on this, but just quickly, it's, I think of it as having three domains. One is the energy deficit and the knowledge and education, the more didactic part of it, where you give them guidelines and goals to follow to achieve a better diet quality, decrease caloric intake, and increase physical activity. Physical activity goal is 225 minutes a week, which is a little bit below what you might hope for weight loss maintenance, but works out to 45 minutes a day, 5 days a week. Behavioral modification is really the cornerstone, with heavy emphasis on goal setting and self-monitoring, controlling one's environment, problem solving. And then everything we do is really highly targeted to the rural setting, and making sure we have the right literacy level. We're addressing access barriers. We're not suggesting people eat fish tacos when they don't have access to fish tacos, and really link it to values of hard work, self-reliance, family first, those kinds of things. We have, standardized treatment manuals. We use commercially available devices and apps. We're not doing any kind of tech stuff ourselves. And we're not testing any special diets or anything like that. It's just a standard evidence-based intervention using tools that are available and focusing more on the care delivery and implementation aspects of it. As a PCORI trial, this really launched me into more engagement of stakeholders and patients. And it was absolutely the funnest part of doing this study. We had a really active patient advisory board who kept things really real, and at times humorous, and definitely meaningful. It took a village to do this. Our clinics that participated, not only did they deliver the intervention in 2/3 of them, but they also all came on as research personnel and consented patients, collected data, entered the data into REDCap, followed up to get people in if they fell off for their data collection visits. They did all of that. All these sites had to come on as research sites with federal wide assurance. And it helped establish a network of clinics that are capable of doing these kinds of clinical trials. So we recruited in a similar way as we did with the breast cancer trial, through clinic referrals and mailings. And in each clinic had a target of 40 patients per clinic. They all hit that target. We had a range around it, so the range was 34 to 44. And again, we had no problems with recruitment for this study, and I was more encouraged about the level of clinician engagement in making referrals on average, but again, a huge range. So some clinicians, all their patients came from a referral in the clinic. Other clinicians remained very hands-off, and all their patients came through the mailing or through family and friend referral. So still a lot of room for improvement and get clinician engagement across the board. These clinics, with our help, accomplished excellent retention over the 2 years of this study. We had 92% at 6 months and 87% at 2 years. This is our characteristics of the participants. Over 1,400 across the 36 sites, predominantly female. That is one area of ongoing need for improvement. And in our current study, we are purposefully asking the clinicians, refer your men, your male patients into this study, many times I don't think of it, the men are also less likely to respond to mailings. This demographic is predominantly white. 46% came from isolated rural towns. And that was because about the same proportion of our clinics were located in isolated rural towns. So we did a good job of really reaching the more frontier areas. And a median travel distance in time to the clinic was quite small, only 9 miles or 15 minutes. That was one of our major lessons learned from this, is don't overestimate travel burden in rural settings. Know your setting. A lot of comorbidities, which were not surprising, except we were a bit surprised about the high level of depression comorbidity, about 40% of our sample. And these are our primary findings. So both group-based approaches did better than the Medicare model of the individual office visits. The in-clinic group visits had a slight advantage in terms of weight loss. In terms of experience of care, they had a much bigger advantage over the telehealth-based approach. Physical activity changes followed a similar pattern, where the group approaches had greater increases in physical activity, with the in-clinic approach having a little bit of an advantage over telehealth. We looked at attendance, and the group approaches, which is in-clinic group, phone group, had lower attendance than the individual, and that's just, it's a standing group time, same time every week or same time every month, and it's not something you can reschedule like you can individual visits. But surprisingly, one of our hypotheses was that telehealth would outperform clinic-based because of travel burden and people's ability to attend, and we were just dead wrong on that. We actually saw higher attendance in the in-clinic groups, and the patients really preferred that face-to-face contact. Travel distance had no effect on attendance for the group visits. For the in-clinic or for the individual visits, there was a small effect where people who lived closer had a little bit higher attendance. For either individual or group visits, travel distance had no effect on the amount of weight that they lost. So some of the kind of lessons learned and opportunities from this study, as I mentioned, and I keep saying this and we keep falling short, but we got to figure out a way to get more men in interventions. The disease burden of obesity among men is significant, and they are definitely an underrepresented population in obesity treatment research. Know your setting. Don't assume travel burden when you're working in a rural location. Group visits work really, really well. It's still our preferred modality, but it's difficult to sustain locally. Patients really prefer the face-to-face contact, at least some amount of face-to-face contact. They also really wanted more meaningful interaction with their PCP during the weight loss treatment. Some PCPs were highly engaged, but many of them were not. I have a quote here, from one of them. He's just not as excited about my weight loss. He doesn't know anything about it, even though he recommended it. He's not educated on what I went through to do this. He's oblivious. I love my doctor, but he's just out of tune. So they're really wanting more of the medical management part of this. Speaking of rural culture, this second quote, I think, kind of highlights sort of the straightforwardness. My doctor knows that I'm very straightforward and say exactly what's on my mind, and that's what she does with me. I mean, she's just will say it straight out, whatever she's thinking, and that's how I like it. I want them to say, hey, straight up, this is how it is, and this is bad. You got to do something. A challenge is really to get more medical management and involvement of the local clinicians while these lifestyle interventions are happening. And this is my last slide. It's this trial that we have in follow-up to our Repower trial that we are currently conducting. We're in the second year of it. We're enrolling 16 clinics in this study. Again, it's cluster randomized. And we're testing a model of care delivery that moves the group lifestyle intervention to Zoom, but it's maintained at a clinic level. So our telehealth arm in Repower, patients were put in groups across different clinics, and they really wanted the local component. So we're keeping the groups locally based with the remote health coach from here. And then we are forcing, if you will, the medical management part by offering team-based care where the lifestyle coach is joining quarterly clinic visits with the patient and PCP to accomplish integrated care across the health coaching and their medical management, so they can be given more pharmacotherapy options, potentially referrals for surgery, and also have their comorbid conditions addressed. So I'm happy to answer any questions about the current study that we're doing. It's ongoing. We have our first 2 cohorts, first 8 practices recruited for this. So takes a village to do this kind of work. We had about 200 research personnel on the Repower study across all of our different sites. And I'm really grateful to our patient advisory board and our community advisory board that help us accomplish this in a realistic real world settings. So with that, I will take questions. And I'm supposed to show this. Do I need to leave this up or should I pose my slides?
Oh, I don't know what, Adela, what do you want us to do? Is this?
Leave it up for a minute or so just to get people a
Okay.
chance if they want to, and then you can take it down.
Okay, great. So thank you so much for that presentation. It's amazing work, and I'll just take a stab at the first question if that's my prerogative. You know, I'm amazed at how biased self-reporting is with physical activity. It's worse than food intake self-reporting. The objective measures, it just goes to show how much the objective measures are really important when trying to understand physical activity's involvement in keeping weight off. So I had a question about some of those earlier trials because I'm really interested in how exercise is beneficial for folks. Did you analyze the biomarkers that you measured and those hormone levels in the context of how much physical activity they were doing, that objective exercise? And, was there something that really stuck out about exercise if you did that analysis?
So we did that in response to reviewers on our paper, and we just adjusted it for physical activity level.
Okay.
So the results I showed were adjusted for physical activity.
Gotcha.
And this has been shown in head-to-head comparisons too, looking at interventions that target weight loss or diet and physical activity versus just physical activity. The weight loss really trumps the physical activity in terms of the biomarker changes.
Yeah.
And they co-vary so much too. But we saw much more contribution from the weight loss versus the physical activity changes.
Gotcha. Questions from the attendee?
You can take the slide down now, Dr.
Okay.
Befort.
Okay.
Heather, do you want to unmute and ask your question, or do you prefer that we read it?
Sorry, yeah, absolutely. So Christy, I typed it in there, but I'm just curious, when you compared the group versus individual, did you postulate or did you test sort of a behavioral mechanism by which you think the group was potentially more effective?
We tried to get at the mechanism from surveys, which is hard to do, like group dynamics. More so, I think, from the qualitative interviews that we did. And our proposed mechanisms were based on kind of older, more psychotherapeutic models of actually that came out of a cancer survivor space, like Yalom's work, looking at, you know, the curative aspects of group therapy having to do with like hope and normalization and information. I mean, there's like 7 different things that theoretically promote better outcomes in a group therapy approach. And our qualitative data tended to support some of those dimensions, particularly the ones I mentioned, which were accountability, information sharing, and the support. But we do see a lot of normalization, and we don't directly intervene on internalized weight stigma in these groups, but it's definitely a component that comes out. And we try to stay very aware of it. And I think one of the more beneficial aspects of it is the normalization of that experience.
Awesome, thank you.
Go ahead, Jamie.
And Dr. Befort, I was really disappointed that Lebanon wasn't the home of the world's 2nd largest ball of twine, but apparently that's what, Cawker City?
Yeah. It's on the way there.
Okay, I was, you know, hopefully you integrate a picture of that next time, because I just love
It's a good idea.
But in my more serious question or comment, and asked you to expound on, was the finding that distance was not as influential as many people sort of reify it to be in terms of this. And I was wondering if you could say a little bit more about what was drawing people to be willing to travel.
Well, I think the biggest thing was the travel time and distance was not as great as we thought it would be. And I think this may be really, you have to know your region and your locality. Almost half of our clinics were located in isolated rural areas, and the patients were coming from those same areas. So they just their travel time was lower than what we have here. So, and these are designated health professional shortage areas. So, I mean, theoretically on paper, the access is, you know, you can sort of cite that as a barrier, but the reality is it wasn't. And I don't know what Eastern Colorado is like in that regard. We have a really great critical access hospital system and rural health clinics attached to those here in Western Kansas. So I looked for data on this, and it's like you can't find it, because you would like to be able to find it in your proposal that, you know, as you're planning, to know from a data standpoint, like what is the actual travel distance that people are traveling to primary care. It doesn't exist.
David Buller has a question. David, do you want to ask it, or do you want me to read it?
I can go ahead and ask it. Hi,
Yeah.
Christie. I just wondered, your statement about men intrigued me. Is the clinic-based strategy not really effective for men in these areas? I mean, is it just not something that they're willing to do, or is there something we can do to improve it, or is there a different way to reach the men?
That's a great question. It's not just clinic-based programs. It's almost all programs in obesity treatment see this. And there's a group in Australia who's done I think a pretty good job, but their approach is men only, like only men, and they focus more on resistance training and high protein, and not as much like kind of restriction mentality, not as much like self-monitoring. But so I think they've done a good job of sort of like understanding men in this area, as far as like what kinds of interventions, short of like male only or men only. I don't know. I've kind of been wanting somebody else to take this on, because I'm not a man. I mean,
Fair
I go
enough.
to like farm shows and stuff with my dad, and I'm like, this is where we need to be. I'm like, all these guys need to be in this program. I don't know.
To follow up David's question, is the sex difference there rooted in that men are just less motivated to do to do something for this health issue, that they're just less motivated?
Well, they get referred less often. I mean, the clinicians are less likely to raise the issue. They may be less likely to, I don't know. I mean, I hate to get into stereotypes, but we see it in our programs, like they're less likely to prepare their own food, It's kind of like if somebody else would help them, they would do it. I see that a lot. I don't know. I'm getting way off, out of science and data saying these things, but I honestly remain sort of puzzled that we are allowed to continue to get away with this in the obesity treatment field. Like we should have to make a statement on our grants that says like how we're going to target underrepresented men for this work.
All right, we
Well,
have a question. Oh, go ahead, David.
Oh, I was just going to observe. You're right. I mean, it's there in a lot of different areas. When you try to recruit parents for things, you get the mothers, not the fathers, and so it's an ongoing, bias in our samples that we just don't have a lot of men.
Yeah, and surface level, like for Repower, we got some men together to help design the brochure, and like that doesn't really help. I mean, it's maybe helps a drop in the bucket. This time, we're really trying to get the clinicians to do more referrals. So we'll see.
All right, we have another hand raised.
Yeah, Sammy Diab, thank you. Great presentation. You commented on you were surprised about the 40% depression in one of your studies. Can you comment on that in the sense, I think there's a link between depression and obesity. What's the cause effect, and what's you think somebody is depressed, maybe they're less likely to participate in clinical trials. So that was an interesting observation for me.
Yeah, I mean, in many studies, like effectiveness studies, that's actually an eligibility criteria. So they'll exclude people with active depression. They do struggle more with weight loss, although if they can adhere, the depression will improve just as much as the weight. I mean, it'll treat their depression too, just from the behavioral activation and structure of it. I don't know if I'm answering your question, but it was, I think, as a kind of real world test where we had few exclusions, I think that's one of the things that will reduce the effect size that you might see and the amount of weight loss that you accomplish. And, also highlights the need for additional referrals to behavioral health in this setting. It impacts sleep, and sleep is also another big thing that can interfere with weight loss.
So do you think if you have a obesity and depression, or obesity and not depression, is there's like, in your experience, different outcomes in terms of these intervention?
Yes, people with comorbid depression typically lose less weight. But if they can adhere to it and, adhere to the guidelines as much as possible, they will see improvements in their depression and some amount of weight loss as well.
Okay, thank you.
There's been studies in primary care where they only work with people with depression and obesity. But when you start slicing and dicing your eligibility criteria like that, it becomes like no longer a sustainable model, because we don't have anything, let alone something just for people with certain comorbid conditions. So we're trying to feed a pretty heterogeneous group from a medical standpoint in the same intervention. And that's where the PCP involvement becomes really important.
Well, great. We're at the top of the hour. We want to thank Dr. Befort for joining us today and for a fantastic presentation. We really appreciate you coming and sharing your time with us. So thank you, everybody.
Thank you.
And thank you, Dr. Befort.
Yep.
Good to
Thanks.
see you, Christie. Come
Good to
back
see
and
you.
visit soon.
I will.